couple of housekeeping comments for you. Almost all of our sessions will be on the main stage again, but from 1 to 2 p.m., we are actually giving you some options. We have 2 breakout sessions. I'm thrilled about these options. One is actually going to talk about music therapy. We have the team from Mount Sinai who will be talking about how they use music therapy for their radiation oncology patients. And then the second breakout session will be led by Candace Henley from the Blue Hat Foundation, and she will be leading a discussion about health equity and disparity with regard to the early age onset colorectal cancer community. So we're very excited to bring both of those conversations to you. If you want to attend either of those breakout sessions, you can choose where you want to go. You actually just click on the breakout session tabs and you can get to those very easily. You could also choose to go to Sunday networking and mingle with others at either time. During the breaks, we also encourage you to go to the lounge. You could watch one of our on-demand videos. And again, as always, you can participate in the networking. We look forward to seeing you throughout the day. And without further ado, I want to introduce you to this morning's keynote speaker, Jordan Karlitz. Just a little bit about Jordan. I want to tell you that he is the GI Division Chief of Denver Health Medical Center. He's also the associate professor at the University of Colorado School of Medicine. Many of you know him from the National Colorectal Cancer Roundtable. He's also one of the co-chairs of this summit. He's been involved from day one for the past 7 years and a longtime standing member of this community. So without further ado, I want to welcome Jordan and take it away, Jordan.
Great. Thanks for the introduction, Cindy. So I'm going to be talking about some of the research that we've been doing over the past 1 to 2 years utilizing SEER data. So if we could pull those slides up. I don't see those yet. There we go. So obviously, welcome back to everybody. And in terms of disclosure, so I do some advisory work for Exact Sciences, and I'm also the Chief Medical Officer of GastroGirl and GI On Demand, which is a virtual care platform. So next slide, please. So as I mentioned, we're going to talk about 2 recent papers that our group published that I think shed some light on the high burden of early age onset colorectal cancer. Both of these studies utilized SEER data in kind of new ways. So the first study that people may have seen, it was published just over a year ago in JAMA Network Open, was entitled Trends in the Incidence of Colorectal Cancer in the US Among Those Approaching Screening Age. And what we did here is we used a unique methodology where we analyzed SEER 18 incidence rates in 1-year age increments. So prior studies really pooled age blocks together, so like age 30 to 39, 40 to 49, et cetera. But we wanted to look at yearly age, so age 42, 43, 44, et cetera, to give us a high definition look of what happens to incidence rates as people approach the screening age, the traditional screening age of 50. And our main question is, what is the increase in colorectal cancer incidence rates from age 49 to 50 specifically when large segments of the population begin average risk screening? So because it was SEER data, we had a lot of cases, about 170,000 cases. And the bottom line is that we saw a 46.1% increase in incidence rate of colorectal cancer just from the age of 49 to 50 years alone. So this finding is really consistent with pre-existing cancers diagnosed with screening uptake at 50. And I think this really supports that there's a large undetected preclinical cancer burden in those in their 40s, and that this is not really reflected in observed SEER incidence rates. Next slide, please. So here you could kind of see the take-home figure here. So on the x-axis, you have yearly age, again, 30, 31, 32, et cetera. And on the y-axis, you have incidence rates. And then you can see that steep incline between 49 and 50, which again supports a large undetected preclinical colorectal cancer burden that is ultimately diagnosed at age 50 when people enter the screening pool. And I think this really argues for screening at age 45 as opposed to 50, because we want to prevent these cancers. We don't want to detect them at age 50. We want to prevent them before they develop. And in terms of case counts, So our study period was 2000 to 2015, and if we estimate the number of colorectal cancers between 2000 and 2015 in people that are 45 to 50 years old, there are about 130,000 colorectal cancers in that age group. So that just kind of can give you some impact of the number of cancers we could either prevent or diagnose at an earlier stage if we were to screen at 45 as opposed to 50. Next slide, please. So this 45 to 50 incidence rate increase was reproducible across different patient groups. So it was seen in all US regions, seen in men and women, different racial groups, and also for colon and rectal cancer. And screening at age 50 really unifies these disparate populations. And I think this really supports that this increase that we saw between age 49 to 50 is due to a screening detection effect as opposed to just advancing age alone. Next slide, please. So here we could see that steep incidence rate increase from 49 to 50 based on geographic region. So yellow is the southern US, green is the Northeast, blue is the Midwest, and orange is the West. And again, you could see that steep incidence rate increases there for all of these different geographic regions. You can see that the absolute incidence rates are higher in the South, but again, that steep incidence rate increase is the pattern that we're looking for here. Next slide, please. And for males and females, you could see a similar pattern between age 49 and 50, although it is a little bit blunted in females compared to males. Next slide, please. You can see almost the same exact incidence rate increase in blacks versus whites, although you can see that the absolute incidence rate is higher in blacks versus whites, which is something that we've known for quite some time now. Next slide, please. And you could also see a similar increase for colon and rectal cancer. The rectal cancer increase from 49 to 50 is a bit lower than colon, and I think the reason for that is because rectal cancers may be more likely to present with symptoms prior to screening detection at age 50. Next slide, please. So this is a really important slide because we actually looked at stage stratification between ages 49 and 50. And you can see start in the kind of in the box in the top right of the figure, you can see that the steepest increase was actually in situ cancers, 140% increase. But then if you look at the y-axis, you can see that the absolute incidence rate increase was actually very small for the absolute incidence rates for in situ cancers are actually quite small. But you can see that localized and regional cancers, so that's orange and blue respectively, show steep increases, and that distant stage is relatively flat between the ages of 49 and 50. Some of the key points of this slide are that about 93% of colorectal cancers diagnosed at age 50 are invasive, meaning they're beyond in situ stage, and obviously cancers that we want to prevent from forming in the first place. Importantly, localized cancers, which some may downplay, but shouldn't be, these cancers have a 10 to 11% 5-year mortality, and most require surgery. And this really argues against length time bias, in which slower growing and potentially less clinically significant tumors are detected with screening at age 50. Importantly, localized and regional cancers can be associated with psychological distress, economic burden, and impaired quality of life. So we really want to prevent the development of these cancers. And in terms of why the 49 to 50 inflection was relatively flat for distant cancers, I think this is probably because these types of cancers would more likely present with symptoms as opposed to being detected with incidental screening at age 50. Next slide, please. So the take-home points for this study is that the steep age 49 to 50 incidence rate increase really supports the presence of this large preclinical cancer burden in those in their 40s that's not reflected in observed SEER incidence rates. And I should mention that some of the arguments that have been posed historically that arguing against screening at age 45 versus 50 include the much lower incidence rates in 45 to 49-year-olds as opposed to 50 to 54-year-olds. But this, I hope this paper proves that this is really a misconception because those between the ages of 45 to 49 do not have the advantage of having preclinical cancers picked up by screening. These patients are mainly undergoing testing for symptoms or family history as opposed to 50 to 54-year-olds. So really comparing SEER incidence rates between those in their 40s versus 50s is comparing apples to oranges. Next slide, please. So this is the next paper I wanted to talk about. This is actually fairly controversial. It came out a few months ago in Annals of Internal Medicine. and it was entitled Contributions of Adenocarcinoma and Carcinoid Tumors to Early Onset Colorectal Cancer Incidence Rates in the United States. And what this study did is it was really the first to analyze early age onset colorectal cancer incidence rates by histologic subtype. So we really want to know what's going on with adenocarcinomas, that specific histologic subtype, because that is the focus of colorectal cancer screening and diagnostic testing. Carcinoids, or neuroendocrine tumors, are actually classified as colorectal cancer in SEER databases, but they have a very distinct pathogenesis and are managed very differently than adenocarcinoma. So what we wanted to do is we wanted to assess incidence rate changes and proportions, shifts in proportions of these subtypes from 2000 to 2016 in younger patients. Next slide, please. So the bottom line for adenocarcinomas is that we did show steep incidence rate increases in many early onset subgroups. So what we did is we actually pooled incidence rates from 2000 to 2002 and compared them to 2014 to 2016, so kind of the study flanks. And what we saw is that there was a 39% increase in rectal adenocarcinoma in 20 to 29 and 30 to 39-year-olds, a 20% increase in colon adenocarcinoma in 30 to 39-year-olds, a 16% increase in rectal adenocarcinoma in 40 to 49-year-olds, and a 13% increase in colon adenocarcinoma in 40 to 49-year-olds. And so this really just proves that what we're seeing is when you kind of when you're looking just at colorectal cancer, is that these incidence rate increases we're seeing, a large proportion of this is due to adenocarcinoma. Next slide, please. However, when you look at carcinoids, it is important to note that they are pretty common. They represented approximately 4 to 20% of all colorectal cancer cases, depending on age group and calendar year. And importantly for the rectum, they're actually quite common. They represented 8 to 34% of all rectal cancer cases, depending on age group and calendar year. Colon carcinoids, on the other hand, were exceedingly rare. Importantly, all age groups had statistically significant increases in rectal carcinoid tumor incidence rates, which were actually higher than the corresponding adenocarcinoma incidence rate increases. And two of the steepest increases from the beginning of the study period to the end for rectal carcinoids were in 20 to 29-year-olds, where there was an 113% increase, and for 50 to 54-year-olds, where there was a 159% increase. Next slide, please. So this slide, unfortunately, I don't have the pointer to kind of guide you through the slide, but you could see that on the top, we kind of broke this down by location. So there's colorectal in column 1, colon in column 2, and rectum in column 3. And then on the y-axis, we have age. So we have 20 to 29-year-olds, 30 to 39, 40 to 49, and 50 to 54. And what this slide shows is the percent contribution to overall cancer incidence rates based on histologic subtypes. So purple are adenocarcinomas, green are carcinoids, and yellow are other tumors that are not adenocarcinomas or carcinoids. And what you can see is that the overwhelming color on this slide is purple, but if you look at the rectum, again, column 3 on the right, you can see that there's quite a bit of green, and that in general, the amount of green is slowly increasing over time. And you can really see that effect on the very bottom right of the slide for 50 to 54-year-olds, where there's a really steep increase in rectal carcinoids. Next slide, please. So the take-home points of this study is that this study certainly confirms that adenocarcinomas, again, the target of screening and surveillance, are steadily rising in young patients, including 40 to 49-year-olds, which certainly supports earlier screening at age 45. And although carcinoids are rising at a faster rate than adenocarcinomas, you could see based on that prior slide that the overwhelming majority of early onset colorectal cancers are in fact adenocarcinomas and not carcinoids. And kind of I underline this point because I think this is the key point. Adenocarcinomas are driving the overall increase in colorectal cancer burden we are seeing in young patients. However, going forward, I think it really is important to always look at adenocarcinoma subtypes independently so that we get a more accurate depiction of the outcomes from our efforts to reduce colorectal cancer risk. So if we include carcinoids, that could potentially bias results. We really want to focus on adenocarcinomas to see if what we're doing is working. Next slide. So this came out a few months after the paper we published in Annals and in Medscape, and the title of this write-up, which I was obviously not involved in this title, was Colorectal Cancer Risk in Young Adults Not as High as Previously Reported. And I want to be clear, this is absolutely not true. As I mentioned and kind of showed to you on that previous figure, almost all these colorectal cancers were purple, or on that figure, or adenocarcinomas. So we actually just published kind of our response to this this write-up in gastroenterology, the journal Gastroenterology, and it's entitled "Adenocarcinomas as opposed to carcinoids are primarily driving increases in early onset colorectal cancer rates," and hoping people could take a look at that if they have the time. And that's it. Thank you so much for inviting me, and it's been just such an honor and pleasure to help organize this event.
Thank you, Jordan. I really appreciate you taking the time to come on this morning to set the record straight. And
yeah, you're welcome. I'm glad. Thanks for giving me the opportunity to.
Yeah, I think it might deserve another conversation, perhaps having you and Becky and Steve Itzkowitz and the fourth author come back and have what could be a very lively conversation in another month or so.
Absolutely.
Okay. So for everyone that's here this morning, we have the next session happening, I think staying right here on the main stage. I think this is going to be a fascinating conversation basically about what it takes to take care of the early age onset colorectal cancer patient, led by Andrea Sursek in the NCU. Stay right here. I'm very excited to see this conversation. Thanks for tuning in, everyone. Jordan, I'll see you later.
Okay, thank you. Bye.
Bye.